is Raelina Tucker, and I'm the District Nurse Manager for Hughes, Okfuskee, Pottawatomie, and Seminole County Health Departments in Oklahoma. Today I wanted to talk to you about the burden of sexually transmitted infections in our communities. As public health professionals, you've probably seen a lot of clients with sexually transmitted infections. But did you know that there are 20 million new sexually transmitted infections every year in the United States? And that leads to $16 billion in direct medical costs alone. There are 110 million total sexually transmitted infections in men and women across the nation. Oklahoma ranks 10th in gonorrheal infections among 50 states and 14th among chlamydial infections among 50 states. Those numbers are from the Centers for Disease Control in 2013. We don't have the numbers for 2014 and 2015 yet, but I'm sure that they would be even higher. Many of these infections go untreated, mostly because a lot of people don't have any symptoms. But even if they don't have symptoms, they can have a lot of health conditions related to that. One of the things is that women are at greater risk of ectopic pregnancy, which is considered an emergency. They can have chronic pelvic pain, and they can also have decreased infertility problems. So we know that sexually transmitted infections cost a lot of money and they cause health issues. So how can we decrease those rates? One of the things that we can do is called expedited partner therapy, and that's what we want to talk about today. We want to know what expedited partner therapy is, how it decreases sexually transmitted infection rates in our communities, and then some of the obstacles that are related to that. CDC says that expedited partner therapy is the clinical practice of treating the sex partners of patients diagnosed with chlamydia or gonorrhea by providing prescriptions or medications to the patient to take to his or her partner without the healthcare provider first examining that client. There's a couple of ways to do that. One, the patient can get a prescription to take to their partner or partners. They would take that prescription to the pharmacy. They get their medications that way. One of the good things about that is they can talk to the pharmacist if they have any questions. The bad thing is they have to go to the pharmacy to get it. They have to pay for it if they don't have insurance, which a lot of our clients don't have insurance. The other way that they can do that is called patient-delivered partner therapy, and that's when the patient actually gets the medications to take to their partner or partners. The good thing about that is they don't have to go anywhere to get it. They already have it there. They don't have to pay for it, so they're more likely to take it. Now, historically, we've relied on patients to go home, tell their partners that they need to go get tested and treated at the clinic. Only about 40 to 60% of our clients are doing that. And if those partners don't get treated at the same time, then those patients are going home and getting reinfected. So how do we know that EPT works? We know that it works because they've done studies in other states. Other states have been doing EPT for a while. And the National Center for HIV/AIDS, Viral Hepatitis, STD, and TB Prevention says that EPT is effective, and studies have shown that patients whose partners receive EPT are 29% less likely to be reinfected than those that are simply told to go to their doctor. Again, it's very important that these patients get their partners treated at the same time, or they're going to just turn around and get reinfected. These are the rates for Pottawatomie County for 2010 to 2014. In 2013, we had 375 cases of chlamydia and 100 cases of gonorrhea. In 2014, we had 426 cases of chlamydia and 102 cases of gonorrhea. Again, we don't have those numbers for 2014 and 2015 yet, but I am confident that they will be even higher. We've been seeing a lot of sexually transmitted infections in our communities, in our state, and across the nation. Now we know that EPT, what it is, we know why it works. Why aren't we using it? Well, there have been some obstacles to overcome, and there's been some legal issues related to EPT. If you look at the map, the green states are a go. They're giving EPT no problem. The other states in orange, which Oklahoma is, We now can give EPT under certain circumstances. The ones in red are still not giving EPT. There are some other barriers or other reasons why clinicians are not giving EPT. Collier, Taylor, Winsett, Mickey, and England in 2011 wanted to know why their doctors weren't giving EPT. So they did this study in Arizona, and they asked all their OB doctors why they weren't giving EPT. And one of the reasons they gave was fear of allergic reactions. In all the studies, there's only been one instance, which is pretty surprising, that there was only one reaction to this medication. And it really wasn't an allergic reaction, it was just an adverse event, and it was nausea and vomiting. So really, as long as you're asking the partner or the patient what their partner's allergies are, it shouldn't be an issue. They were also concerned about malpractice or liability issues, which it turns out so far there are no liability issues, or there haven't been any malpractice suits around EPT. Some doctors think that the practice is illegal, they just don't know what their laws are. So that's an education issue. We need to talk to our clinicians about that. And then some of them, their clinics don't allow them to give medications to anybody that they don't see, and that would just take some protocol changes in their clinics. The other question is, if we were to give these medications to our partners, would they take it home to our patients, would they take it home to their partners? And they wanted to know this in New York as well, and they have a clinic kind of like ours, it's a public health clinic. So in their qualitative study, they found that almost all of their participants, which was 92%, said that they would take it home to their partners. And of those that would take it home, almost all of them, or 92%, said that they thought that their partners would take it. So we know EPT works, and we know what the barriers are. Other states have overcome those barriers, and I feel like Oklahoma can overcome those barriers as well. And CDC even recommends EPT to be given to partners. And actually the Oklahoma State Department of Health has recognized this issue, and we're going to be giving EPT to our clients through the public health department system. We have protocols in place, we're ready to go, except we had no money to buy the medications. So hopefully this is the new fiscal year. We should get money to get medications, and hopefully by starting EPT in Oklahoma, our sexually transmitted infection rate should decrease. Do you have any questions? Thank you.